really, we are sorry to have to move people through so quickly, but I think, what we're trying to do is give you a sense of the richness of work that's going on at the local level, and it was very exciting to hear some of the peer work that's going on and the wellness work. So I'm going to turn it over to San Diego, finally here.
Okay, well, 3 of us are presenting, and Gail made me promise that I was going to condense into 5 minutes 5 years of grueling, detailed work to try to transform a system. So I do have an extra 20 seconds, though, 30 seconds, because I need to note that this presentation is going to be about a SAMHSA grant project, but it's in the context, it's one small part of a large system transformation that we've been achieving in San Diego County regarding integration, getting ready, building medical homes, getting ready for accountable care organizations, managed care, and so forth, ACAs, accountable care organizations. And what we did in this instance was to, as a county, serve as a convener, and we enlisted the help of some independent organizations because most of our behavioral health services are provided by contract organizations, and our primary care is provided by a huge complex system of about 100 different federally qualified health center clinics run by 10 or 12, or actually it's 24, entirely independent federally qualified health centers. So it's a very complex system, and this is one small part of it that fits in with what we call the shared provider model. So stepping to the plate was Philip Hanger, who was omitted from the program, and MHS Inc., Mental Health Services Incorporated, which stepped up as the lead organization in this project, the SAMHSA project. They are the fiduciary lead, and then also on board in another pairing of clinics is the Community Research Foundation. I have Dr. Philip Hanger from MHS Inc., who was omitted from the program, and Dr. Diego Rogers, who is here from CRF. And since I don't have any time, I won't tell you who I am. Okay, I need to say that this is, our project was really the forerunner of a larger agency and county initiative to improve the lives of the 3 million citizens of San Diego County. It's called Live Well San Diego. This is part of one component, building better health. We also have living safety and thriving. Okay, so what we call the paired provider model, what is it? As I say, the SAMHSA project represents specific pairings of clinics within this paired provider model. Well, the reality is that we talk about the unmet health needs for our mentally ill population, but just as important from a societal standpoint and to the primary care community is the fact that most visits to primary care doctors are really based on psychosocial needs. So we see this as the ultimate prevention, to intervene with primary care in their office when people aren't seriously mentally ill. So our paradigm shift is one where we have fostered the pairings of literally dozens of behavioral health clinics and primary care clinics, developing new relationships, and our thought was that if we could develop the relationships, which is the most important thing, and I'll go into just a little detail because I won't have time. This is sort of a 30,000-foot view. If you'd like more information, you can contact me. But our thought was that the funding's going to follow. If you have units of providers, behavioral health, primary care with separate funding streams, ultimately through accountable care organizations and a managed care environment, there will be natural partnerships. And if we have a continuum of care that serves the needs of our clients and does upstream intervention in the primary care office, it's going to really affect outcomes very positively. So our paired provider model has been supported not only by the SAMHSA project, but we have a whole variety of specific integration pilots through MHSA. And what we did was to use the low-income health plan in behind the paired provider model to carve in mental health so that we could help develop capacity, competence, and confidence for primary care clinics. So the idea here is a shared ownership, and this is a big change. It's really thinking about population management. What we say in these pairings is that, listen, instead of you thinking about your clients, you thinking about your patients, think about the combination. you both own the whole spectrum of clients, because some of the people you see now in your primary care practice who aren't seriously mentally ill could get that way. So we wanted to take joint responsibility for that entire population. And in this relationship, you have mutual support, easy bi-directional flow of clients and information, development of new competencies, a lot of care coordination. And this model is actually a model that I borrowed from concepts about other scarce medical specialties. You want to preserve your scarce medical specialty for the people who really need it most. You want your dialysis units for people who need dialysis. You want your cardiologists for people who really need cardiology. We want our system for people who have complex psychosocial needs that can be addressed only through our expertise, which means people with lesser degrees of illness could be addressed, their needs could be addressed within primary care. So what's the quid pro quo? What is in it for primary care clinics? We refer to ACE, Access, Consultation, and Education. Part of what we've done is to transform our adult system under Piedad Garcia, our adult system chief. We've transformed our adult outpatient system so that it is now a risk-based, on-demand service system. This has huge impact because it means the primary care doctor knows that he or she can get their patient in to see somebody right away. We provide a lot of consultation and education as well. This is a schematic. I think this is about my last slide. So let me just say that as people are sicker, they would be, or more acute, they'd be more on the behavioral health side. As people are less ill, they'd be on the primary care side. The boundary between the two will shift over time because we want to help primary care develop competence, confidence, and capacity. This means that we want them increasingly to feel comfortable treating lesser degrees of mental illness, lesser acuity, lesser complexity. We are seeing this happening so that eventually the goal is that people who are stable and not really in recovery within our system, coming in for a doctor's visit every 3 months, not getting anywhere, we want to see them mainstreamed. Peer recovery is an important component of this as well. And the response from our community, from our consumers, has been overwhelmingly positive. They like being able to go in to see a primary care doctor where instead of just seeing the psychiatrist every 3 months in one of our clinics, they'd much rather go in and get comprehensive health care. So there's some contact information, and now let me introduce Dr. Philip Hanger from MHS Inc., who was left off the program.
Thank you, Marshall. I do realize that one of the benefits of being off the program is I'm also not on the presenter evaluation form, so therefore I can say whatever the hell I want. There's no repercussion. Now we're going to narrow down to the specific SAMHSA pairing, and this was certainly a collaborative effort across the community. You see the various organizations. Marshall mentioned the Council of Community Clinics. That's over the 150 different clinics, the FQHCs in San Diego, as well as the various providers, partnership with the county. And this opportunity gave us a chance to focus on the need for health care services to the seriously mentally ill in the behavioral health clinics. Now, the strategy used was pairing the mental health and the primary care clinics, but embedding a nurse care manager, nurse practitioner, embedding the staff in the behavioral health organizations so that there could be direct services, so that there could be education to the staff, so there can be a liaison to the primary care, available mental health consultation back to the primary care for coordination of care. The expectation, the goals of this, of course, number one, make the links, show that they work. Make the connections of doing the right thing and getting the primary care behavioral health clinics to be working more collaboratively together, work out the problem areas. Number two, start providing physical health screening, the assessments, being able to make the referrals for more ongoing services. As you know, the behavioral health clients do not get physical health services. So starting the services with a screen in the behavioral health and then making referrals. The third is beginning wellness programs in the behavioral health programs. Starting those wellness programs, as Scott had mentioned as well, very similar. The concepts are well known within the hospital and physical health communities, but beginning to implement those within the behavioral health communities. And lastly, making that linkage of the information exchange, starting the continuum of care across that we have very well within our system of care in the mental health side, but establishing a system of care, a continuum into the physical health side. So working out the problems of sharing data, sharing information through that continuum of care. This last is, unfortunately, very small, and I didn't have the assistant medical director that Bob had benefit of to have really, but this shows that we came together as in the middle of the project advisory committee to be able to show that continued effort of this is not just a mental health project or a physical health project or a county-driven, but a consortium, a collaborative of all of us coming together. And then the pairings. My company, Mental Health Systems, has a pairing with one of the primary care, and Dr. Rogers for Community Research Foundation has another pairing. And I'm going to let Dr. Rogers come up now and talk about the specific outcomes now as we narrow in on how we work this project.
Thanks, Phil. Okay, so I'll speak briefly about some of the outcomes here, and one of the things to keep in mind is how big San Diego County is, and so we had a pairing up in the north part of the county between a program of mental health systems as well as neighborhood health care, and then in the southern part of the region was one of our programs, the Community Research Foundation, with Imperial Beach Health Center. Just as a note, San Diego is very diverse, largely Latino population, and in the south pairing, that pairing is actually 1 mile from the U.S.-Mexico border. So in terms of demographics, we saw a big penetration of Latino clients, which interestingly, when you look at it from a cultural perspective, most Latino clients actually would start in a primary care setting versus going to the behavioral health setting for mental health services. So it's almost like a return back full circle there, and also part of it, I think, of mainstreaming as well as being culturally appropriate. In terms of some outcomes just in general, I know we don't have data and nice bar graphs to show, but basically in the first 3 years, there was 900 total unduplicated participants at both pairings in the 3 years. According to the national outcome measures through SAMHSA, there were self-reported improvements in the categories of overall health, daily functioning, and social connectedness. There were also positive changes noted in 3 physical health indicators of BMI, blood pressure, and weight. And another major outcome, which I think is really big, especially on the behavioral health side, is the increased behavioral staff awareness and goal of accessing primary care services for our SMI clients. This was a big shift for our staff to now start thinking holistically and from a more integrated perspective. And honestly, it wasn't a hard sell at all. Our staff, especially the case management and care coordination staff, who've really kind of struggled trying to tie services together around for our clients, we're just thrilled and ecstatic to have now on-site nurse care coordinators and care managers on site and be able to do initial screening or behavioral health assessment and then actually be able to walk over a client right over to a nurse and see that happen right away. So our staff really embraced that. Of course, then there were challenges, and certainly this is down more in the micro level here. One of the interesting phenomena that occurred was initially, and I'll say this about the broader community as a whole, not about our partners, because certainly the partners that we ended up pairing with were already primed and open to this kind of partnership. But certainly there was a sentiment among the FQHC community, providers and clinics as a whole, that they were concerned about getting a huge number of referrals in this paired provider model of, wow, you're going to start sending us a lot of unfunded clients, and that's going to affect us. On top of that, you're going to send us folks who have complex SMI needs and in some cases going as far as saying we don't want those clients in our waiting rooms, not realizing that, of course, they were already serving them in terms of those that were accessing primary care services. So there's a lot of relationship building and stigma busting that happened, but certainly in terms of the pairings, we were already working with open and primed partners. There was also a big culture shift both for the behavioral health staff as well as the primary care providers. And certainly when you look at things such as cultures of interruption, episodic care, and duration of services, each kind of camp, so to speak, has its own way of how they would define that and how they operate accordingly. So there's a lot of culture shift that needed to happen. Certainly behavioral health staff not used to having a lot of interruptions and had nurses kind of running back and forth between the offices, and the whole kind of tradition of closed door and quiet space and that sort of thing really needed to be shifted, as well as then the primary care staff kind of learning and understanding that, our appointments are not 7 minutes, and so, kind of really needing to wrestle and change with that. We also had the challenges of each paired actual clinic having their own EHR. The behavioral health providers in San Diego County all use a common EHR called Anasazi that the county coordinates, and all the FQHCs have their own EHRs. So they have multiple EHRs, and then, of course, there's no interoperability that exists at this point in time. So there's a lot of workarounds and things going back to the archaic faxing and keeping logs and making hard copies of this to put in that chart and vice versa still have to kind of play out at that level. And then here was an unintended consequence that happened, that as then things progressed and as our clients became more stable and we're getting now total care over at the primary care sites, from the behavioral health specialty sites, we were graduating clients over to the primary care sites. The behavioral health clinics ended up having populations that were more acute and more complex in terms of their needs. That's really good public policy, because as we graduated clients out, we were able to make more room and capacity for folks who really needed the service. However, that trade-off and challenge was now our staff were really like, everyone on everyone's caseload, so to speak, was really now more urgent, more acute, and so the staff really had to kind of stretch and grow with the level of crises and acuity levels that they were starting to see. So I see that I'm out of time at this point, so at this point I'll just stop. Thank you.